Welcome back to Between Two White Coats, a podcast designed to help you be the healthiest version of yourself. I'm Dr. Michelle Plaster, a family medicine doctor.
And I'm her co-host, Amber Foster, a family nurse practitioner. In our combined 30 years in medicine, we've seen a lot.
We're discussing key issues surrounding health and wellness, answering some of our biggest questions, overcoming health obstacles, and giving patient-centered advice in hopes of educating you and providing the tools you need to live a healthy life.
If you find our podcast helpful, please consider subscribing so you don't miss an episode. And don't forget to leave us a 5-star rating and review. This will help other people find our podcast.
Thanks for joining us. We look forward to serving you. Welcome back to Between Two White Coats. How you doing this morning, Amber?
I'm doing fabulous because look at our new background.
Yes, for those of you joining us on the podcast, you are not going to recognize that we look a little bit different. However, if you go into YouTube and look at us, you will see a brand new background. We have a beautiful wallpaper behind us that we are in our new wellness center now.
Yes, finally. We've been talking about it for a while on the podcast, and it is so nice to be in here.
It is so nice to be in here where we are talking about how to keep people healthy as opposed to try to get them back to healthy after they get sick.
Yes.
So today we have a topic that is near and dear to me to talk about on the podcast. And I just want to throw out for people to think about for a second. There is something that kills more than 2 people in the United States every hour. And it is something that I think is grossly overlooked. And so think about what you think that might be. And we
Give us your best guesses. Say it out loud in your car.
That's right.
What do you think it is?
What do you think it is? And so what kills 2 people every hour in the United States is skin cancer. This is what my mother died from, malignant melanoma. We have it in my family. It has really brought my awareness to a heightened state.
Same.
But I will say that growing up in the great United States of America, skin cancer was not something that we cared about at all.
I mean, I remember how in the world did my mom not know that I was putting baby oil and like hairspray on my skin? Did you ever do that?
Okay, baby oil, yes, but can you please elaborate on this hairspray because that one's new to me?
Well, I don't know if it was really hairspray. It was Afro Sheen.
And was it supposed to get you a better tan?
Yeah. Well, honestly, I just burned, which is exactly why I have skin cancer.
Yes,
and we would spray this on ourselves in Alabama, me and my friends.
In Alabama, too.
Yes, in the worst southern
in the
states.
hot sun. And for those of you who have maybe only met Amber on the podcast, I'm just going to let you know she is very fair-skinned, blonde hair. Her son has red hair.
Well, you're fair people.
Yeah, these are not people
smart.
who need to be getting much sun exposure at all. I would do the baby oil, lay out in my backyard in Ohio. The entire purpose of beach vacations was to get as dark as possible so that you could return to school and show off your good tan.
People would be jealous how great you had looked.
I honestly cannot count how many times I've had a significant burn. And when we were growing up, when you went on field trips and other things, they didn't put sunscreen on you. So I remember as a kid going to a summer camp, and it was one of those summer camps on a little man-made lake. And it was just a hot day, and we got so sunburned. We were at this lake all day. No one put sunscreen on us. And I remember my sister and I just sort of unable to move as fried as...
You get in the shower, and it is like...
Everything hurts. You move your skin, and it hurts. And, you know, statistically, every time you get a sunburn, you greatly increase your risk of skin cancers. And so we have to prevent those sunburns. And so, you know, the good news is we know better now. And I think even as parents across the board, not just parents who work in healthcare, but parents across the board are doing so much better. I get stuff from my son's school that says, hey, we're going to be going to this field trip. We're going to be outside. Send the sunscreen in their bag. And and the teachers are helping to make sure that we're not getting all these sun exposures. And
even products now, like a lot of baby swimwear will have like the SPF stuff. So like I think as a culture, we're doing a better job of making people be a little bit more aware. Like I've seen the things where you can put like the sticker on the baby and it'll show you how much exposure, it'll change its colors. You know, like a lot of the swimsuits now have SPF, or I'm not even really sure how they do that, but where it's protective.
Yes, and you don't have to keep putting on the lotions.
Yeah.
You can actually just put them in long
sleeves.
sleeves, put a hat on, these kind of things. So let's talk a little bit about skin cancers in general, educate people about the different types of skin cancers, and then we'll finish up, with what we need to know, what we need to do, how do we protect ourselves from this. So skin cancers in general, there are 3 different types of skin cancers: basal cell, squamous cell, and melanoma. Most skin cancers are basal cell, and thank God, because that is a very non-invasive, does not kill people. And so the majority of skin cancers, when people say, I have a skin cancer, the majority of those are going to be basal cells. What do we look for in basal cells? What do we try to recognize? Because basal cells are a skin cancer, so we don't want to ignore them. They should be zapped off or cut off to make sure that there's not a problem.
Yeah. Often they can be scaly, shiny. I honestly will have patients come in and they'll be like, what do you think about this? And I'm like, get it cut off, because I've been wrong.
Yeah.
Like I literally have said, oh, I'm worried about this lesion. This one looks okay. And then they go to the dermatologist and they take them both off. And the one I thought was okay was that not. And the one that I was like, oh, I'm worried about that one was a big bunch of nothing.
And I think that's true for all of us in trying to recognize these kind of things in the skin. So the brown lesions, kind of flat and scaly, red patchy, it can look like, it can look like a lot of different things. They're normally smaller. They don't have that really black appearance of a melanoma. But if there is a skin lesion that has changed, so if you've had something that looked exactly like this your entire life, whether it's, a birthmark or a mole, but if it starts to change on you, you need to have it looked at. You need to have it checked out. And more times than not, I say, hey, look, better to be in the trash can than to become a problem. So getting those things addressed, getting them shaved off, the only way we really know whether something is a basal cell or something more serious is to look at it in pathology. Yeah. And so we have to shave these things off and then send them to the pathologist, and then it'll come back and say it's a basal cell.
Yeah.
Basal cells are named for the type of cell that they come from. So the skin has multiple layers, and the base layer is the basal layer, or stratum basal. And those types of cells that are in that base layer are the ones that tend to become the problem in basal cell carcinomas. But basal cells are serious things. They're the least serious of the skin cancers, but they've got to be removed. Yeah. And the majority of skin cancers will be these basal cells. The next more serious and next most common type is squamous cell. So after basal cell, the next most common type would be a squamous cell carcinoma, also named for the type of cell that it develops from in the different layers of skin. Squamous cells, in my experience, the scab that won't heal needs to be looked at. If you have an area that's scabbed, and most people will justify these things to themselves. They're like, well, I tend to pick at it. If I just leave it alone, it would heal. I don't care either.
Men will say they're shaving and they cut it when they're shaving.
Yes, because it's most common that all of these skin cancers are going to be in your most sun-exposed places, like your neck and face. So when you shave, you might hit these kind of things. But if you have a scab that won't heal, you either need to put mittens on for 3 weeks and see if you can get that thing to heal and stop picking at it, or just go to the dermatologist or your primary care doctor. But the squamous cell carcinomas are much more serious than the basal cells. Squamous cell can metastasize. It is rare. From the research I was doing, it looks like less than 10% of the squamous cells will metastasize. But remember, metastasize means spread. It can go to other places. It can go to the surrounding lymph nodes. And so in those scenarios, you've got to be careful. It can become a really serious problem. Yeah. Amber and I were looking some stuff up before we started recording on just putting stuff fresh in our brain on skin cancers. And there was a case that I was like, Amber, look at this. And so it was a squamous cell carcinoma on the side of someone's temple on their head, which again would be a really common place for sun exposures and for problems. and it was misdiagnosed as a cyst. And the reason that we were so intrigued with it is it looked
just
exactly like a cyst.
I would have
called that a cyst 10 out of 10 times. And so that really brings to our attention that you don't know what these things are until you look at them under the microscope. You've got to send it to pathology. So it's easy sometimes for us to say, oh, it's probably a normal skin lump or bump. But we just don't know. And so certainly something new that didn't used to be there, if we want to err on the side of caution, we look at it under pathology and then we can make a confirmed diagnosis. Otherwise, it's an educated guess and we can get those things wrong. What happens when someone has, when someone has a basal cell, they're normally small and it's normally something that you say, well, we shaved it off or we froze it. It wasn't very invasive and it happens right in the derm or primary care office and doesn't really require stitches or anything. It's a little scab and you walk out. Basal cells, not big problems, gotta go, but easy to get rid of. What happens with squamous cells when we confirmed, we take a little piece of it, we send it to pathology and we say, oh, this isn't a basal cell, this isn't a nothing, this is a squamous cell carcinoma.
Yeah. I think often patients will get confused because they'll talk about, hey, we need you to come back. And so they're like, well, you know what it is. Why do I have to come back? And so often there's something called margins. And so we can tell based on under the microscope and with pathology if they were able to get the entire piece gone.
Yes.
And so sometimes things that are like literally the size of a pencil tip will end up being several inches wide because the margins were not clear.
Yes.
And you want the margins clear because you don't want to leave any potentially cancerous skin still there. And so I think sometimes that's a frustrating thing for patients is because like we can do things like punch biopsies, which honestly kind of looks like a hole punch. Like it literally is just a little puncture in the skin. We can scrape them off. Literally just taking a blade and scraping the top of it off. But once you start dealing with squamous cell, if you're trying to see how large it is, even basal cell, like I had one on my nose and I called you, I was like, dear God, I'm going to have to get Mohs which we'll talk about that in a minute, because they ended up having to take a lot more than the actual lesion itself.
Yeah. Was that a basal cell or a squamous cell?
It was keratosis. I'm like, this has got to be cancer. It's bleeding. It's on my face because, I did the baby
so
oil.
it ended up being a benign.
Nothing.
Yeah.
But I was like, no, I was, because I am so fair and did dumb stuff. I was like, please take this off.
And when it comes to, the places on your face, like your nose, it's a very common area. Ears, very common area. So if you have any new lesions in those areas, needs to be looked at. And so Amber said a couple of important phrases that I think people have heard that we can clarify. When there is a lesion that is new, looks problematic, needs to be investigated, then we're going to biopsy it. The biopsy means we're going to take a piece of that tissue, we're going to look at it under the microscope. The pathologist will be able to say, this is exactly what this is.
Like you said, scraping and like the punch biopsy, those are just mechanisms for us to remove the lesion from the skin.
Yes. And so there are two types of biopsies, and there are appropriate times to do either. A shave biopsy is a little razor blade, and you just sort of take, and very simple to do. Most physicians can do this in their office. And you just sort of take a small shave, and it's more superficial. Sometimes you can see when you do a shave biopsy, totally normal to the eye, totally normal skin underneath, and you think, okay, this was probably a very superficial lesion, close to the surface. And we're going to send it off and just make sure. We don't take much off in our office without sending it for pathology. Because not only are we not dermatologists and not expert eyes, but even the things that under expert eyes can look benign can end up being a problem.
Well, I'll do, even just for pediatric patients, I'll do shave biopsies for things that might be fungal or, so there's other reasons that we may do a shave biopsy. It may not always be like, I'm worried about this being cancer.
Because the bottom line is we shave off a bit of superficial tissue, we send it to the pathologist tells us this is what you're looking at, this is what they've got. So it's a great confirmed diagnosis. Or there are some things you can do in office, like look at it under the microscope yourself and see, does it look like fungal cells, fungal pores, things like that. And then the punch biopsy is a different, and I have had a couple of scenarios in my career where someone should have got a punch biopsy when they got a shave. The punch biopsy goes down deeper. When you have skin lesions that look problematic, you're going to figure out what to do next based on what it is. Is it basal cell, squamous cell, melanoma? Those would be your three cancer issues. and how deep it is. When we're talking about melanomas, whether they have crossed the border of the skin down into the dermis or beyond, so out of the epidermis, the outer lying skin layer, into the dermis beneath it, yes, makes a difference in how aggressive this cancer has already spread to. And so only a punch biopsy is like a hole punch. And you're going to push down into the skin and you're going to get all the layers of the epidermis and probably a little bit of dermis so that you can really see how deep is this growing, not only how much on the surface. And Amber brought up the point that sometimes people are like, I do not understand this super aggressive doctor cut out half of my face when all I had was a little bit of a spot. Well, you might have only seen on the surface a very small area, but it could have grown deep and it could have grown wide under the surface. And we have to get all of those cancer cells. You leave a cancer cell behind and you've done nothing to remove the problem because that one cancer cell grows fast, replicates, and becomes a problem. And then you've got the same problem a short period of time later. And so they need to get clear margins, which means they are going to cut out the problem and then go look at it under the microscope and see, is it all healthy cells on the perimeter? And if it's all healthy cells below it and on all the sides of it, then we think we've got all the cancer cells. And if it's not all healthy cells, then they go back and get more. And so Amber mentioned Mohs surgery or Mohs procedure. It's spelled Mohs. It's an interesting, I'm guessing that's named after a doctor who invented it, but I honestly can't say where that comes from. But probably a smart guy's name. Yep. And so Mohs surgery, people are specifically trained to be able to do Mohs surgery. It's frequently able to be done in office, and they numb the area, and you're awake for it, and they take out what they think they need to get. They take it and look under a microscope right there. You're still laying on the table waiting for them to come back. And they say, hey, on the undersurface of this, we still have some cancer cells. We don't have clear margins. So we're going to go in and get those. They go look again. And so they may go back and forth a few times, but they don't let you out of the office until they have clear margins and they know that they've removed all the cancer cells.
And these are specialists, like super specialists. Typically, they are dermatologists that have been specifically trained, or plastic surgeons that have been trained for this. Because if you were to Google Mohs, it is a very interesting process how they do this surgery. And so, anyways, just make sure that if you do have to have that, you are going to someone that is trained.
That is right.
To do that.
That is right. And to that point, the training for dermatologists, like the training for any medical field, is really specific to that person. Yeah. So as someone could go to a dermatology residency and they could have special interest in aesthetics, and they could spend their whole career working on reducing fine lines and wrinkles, giving Botox, doing procedures.
Those are the ones I want to see.
I don't want to see
the
people.
Mohs. I mean, the Mohs people are brilliant.
Exactly.
We have a friend that's a Mohs surgeon, and he's brilliant.
But
I prefer to see the aesthetics.
Shout out to Dr. Campbell.
Yes.
We appreciate you so very much. And he's taking care of my family members. He's a fabulous person.
Yeah.
But Dr. Campbell's training is different than some of those other people who may have more special interest in aesthetics. Or you could have a general dermatologist who does a little bit of all of it. Mm-hmm. But Dr. Campbell and people like him have gone on to do specific training in Mohs surgery. So he's done a lot of extra training to be able to be an expert in Mohs. A lot of these skin cancers exist on people's faces, and so you want someone who, who can take a large piece of tissue, and you don't look like someone took a large piece of tissue.
I have seen patients just literally lose half of their nose.
Yes.
Like, we're not talking about a little spot on your face. I mean, it is significant tissue.
Yes. My dad, when I was probably in high school, college, had a basal cell on his nose and went to a general dermatologist. This was in Ohio. I didn't have any idea who the doctor was. And the general dermatologist cut the basal cell out, and my dad's nose was disfigured for 20 years of my life. Friend of ours who's an ear, nose, and throat here, who is a great surgeon, saw him for something completely different and said, let me fix your nose. And fixed it. So you do have to be careful. You do want someone who's experienced. It is important that people do this right. And people like Dr. Campbell who do most surgeries can also do additional training in skin cancer. And so if you have a high risk of skin cancer, if you have a history of skin cancers, you're going to want a dermatologist who does skin cancer more than they do Botox. You really want to shop around for a dermatologist who has special interest in skin cancer.
For sure.
And so we've talked about basal cell carcinoma. We've talked about squamous cell carcinoma, which is then the next more serious type of skin cancer. Squamous cell can metastasize, but rarely does. And so there are times when they remove all of the squamous cell, they get the clear margins, and they may need to do a little bit further to look for metastasis, like look at surrounding lymph nodes and other things. And this is where you need a well-versed, experienced skin cancer dermatologist so that they can be aggressive to know, I need to go ahead and get this node that's near the area, lymph node, and make sure that we don't have metastasis, because squamous cells can be serious, but thank goodness that they rarely are. And then the third type of skin cancer is the one that we really don't want to have, and that's melanoma, or malignant melanoma is another way that people phrase that. Thank goodness less than 1% of skin cancers are malignant melanomas. Malignant melanomas are the dark spots. They come from melanocytes. So as we've said, all three of these skin cancers are named based on the type of cell, and the type of cell that becomes a melanoma is a melanocyte. These are the types of cells that create dark pigmentation. Melanocytes exist in that lower area of our skin, in our epidermis, and they work as an umbrella to protect from UV light. And so the more that you expose to UV light, the more that your melanocytes have to do and become active, and the more that you create risk for melanoma. Malignant melanomas can be terminal. This was my mom's cause of death. And we need to take them very seriously. Malignant melanomas not only are serious skin cancers, but they are genetic skin cancers. So I have a completely different approach to, I already was doing annual skin checks, but I have a completely different approach to my skin health after knowing that I have a family member that had malignant melanoma. And so I made sure that I not only get my skin checked at least once a year by a dermatologist, where I strip down and
I was going to say, explain that to them, because I have a funny story about that.
Yes. So I go to the dermatologist once a year for a skin check. It's just like I would come to my primary care for my annual wellness. It's my annual skin wellness. I strip down and they look everywhere that they can for hiding areas that could be problems, things that have changed from the prior year. They look in my scalp, they look in my skin folds,
Look in between your toes. Mine looks in between my toes.
Yes, absolutely. Every area that you may have a surface of skin, and they really do like the between the toes and the skin folds and things, because that's the area that you might not see. Look at your back where you can't. So I do this myself. I'm always trying to just be familiar with my own skin and see how much I might have changes in my moles. I'm a freckly and mole person, and so I have to kind of observe if something's changed. Dr. Campbell and friends that take care of me are so great, because I am ridiculous when I go in there and I'm like, I think this one's changed. Could you just shave it off, please? Just get rid of all of it.
Yeah. Same.
And they're very nice and compliant. And they always shave normal stuff off based on my demand for them to do so. And they smile and not give me a hard time about it. You also have.
Well, and I was going to say our insurance, so my personal health insurance, pays it as a $0 copay. So it is an annual preventative thing. So you may want to check on that. But I do schedule an annual skin check. I am so fair. I already told you guys I used baby oil, and I did tanning beds because we went to prom.
I did too.
And we wanted no tan lines for prom. And so, this one particular year, I took off of work. I take off of work for these annual preventative things, like everyone should. And I went and did the dentist, and then my daughter was with me, and we had moved. And so I took her with me so she could eat lunch with her best friend. And so she ended up having to go with me to the dermatologist. So I am, naked underneath with my robe on. And then my girl comes in to, the PA that I see every year. I called her my girl because I feel like she's my friend. And so she's looking at me, and my daughter the whole time is like jaw to the ground. I cannot believe you are letting her look at your skin. And I'm like, baby, I did some really dumb stuff, and I'm so fair that I do not, like, if you can take it off, like, I don't care.
But I love that you took your daughter to do this, because it normalizes it for her. It lets her realize that this is not the time to be modest. Like, let's get the whole skin looked at.
Yes.
So our recommendations on avoiding these things, because the bottom line really is our skin is our largest organ and we have to protect it and take care of it. It is exposed to so many things. Do not have sunscreen be the thing that you put on once you get into the sun. I think you should have your lotion sitting right on your counter. Your face creams and moisturizers should have SPF 40 or more. Put it on every morning. Before you even get exposed to the rays of your computer, inside lights, or the sun, you already have this stuff on. Have your lotion that you put on, particularly in the summer, sit right there. And before you even get dressed in the morning, just put lotion on that has SPF in it so that you are always protected. Remember that when you're out in the sun or you're getting repeat exposures, you need to reapply. And I've gone to really wearing a rash guard shirt as part of my swimwear, because then I don't have to worry about reapply, and those long sleeve clothes just protect us. Wear a hat, protect your face. Umbrellas. And recognize that the most beautiful you is not the suntanned you. It is the healthy you that doesn't have skin cancer. Thank you for joining us today to talk about skin cancer. This is something we can prevent. So let's make the right decisions so that we don't have to worry about these things. And we encourage all of you to have a dermatologist as part of your preventive visits. As you get older, this becomes even more important because of years of built up sun exposure. So shout out to all of you dermatologists out there. Thank you for the work you do. And if you don't have one, we encourage you to get one and get those annual skin checks. We'd like to leave you on a good note. So today's Tell Me Something Good is brought to us by our very special medical assistant, soon to be physician assistant, Kelly. Kelly, tell me something good.
Yeah, so I've been working here for 2.5 years, so I'm excited to announce that I'll be going to PA school this summer. So I'm super grateful for this job that has prepared me for what's to come.
So I think something good is new chapters. Yes. I say all the time that sometimes we get to be just a few chapters in someone's life, and what a blessing that is. We will miss you, Kelly, and we appreciate all the work you've done for us.
Thank you.
Thank you for joining us today, and until next time, take care of yourself.